All present. Everybody present now? Okay. So the topic that I supposed to give is rhinosinusitis, which fall under inflammatory diseases of the nose and paranasal sinuses. Okay, as you all know, inflammation by definition is a body tissue response to harmful stimuli. Example, the pathogens, irritant, tissue damage, and the function of this inflammation is to eliminate the pathogen or cell injury and initiate repair. So in our case, in nose, most common inflammatory diseases is rhinitis or rhinosinusitis. So in the classifications, hold on. Okay, in the classifications, we divide rhinitis or rhinosinusitis into infective and non-infective. So two big heading, and under infective, there are acute rhinosinusitis, subacute, and chronic rhinosinusitis, which we can differentiate from the durations of the disease. While in the non-infective, we can further divide into allergy and non-allergy type of rhinitis. Okay, for you, for the information, I think you might be having slight confusions. Why rhinitis? Why sinusitis? So basically, rhinitis is inflammation of the mucosal membrane of the nose, and sinusitis is inflammatory reaction of the mucosal membrane of the sinuses. So if you go back to the anatomy, nose and paranasal sinus are interrelated. They are interrelated. So normally when we talk about nose, we must talk about sinus as well. And the sinus, the what we call more accurate name is paranasal sinuses. So all these air spaces or sinuses, I think you all know kan, air spaces situated near the nose, paranasal sinuses. Okay, so why it is situated there? Because all the opening of the sinuses are in the nose. Be a big sinus or small sinus, all the sinuses open in the nose. So basically, when we scope the nose, we cannot see the sinus because the sinus is at the periphery or at the sides of the nose. But we can see the opening, or we call it ostium of the sinuses. So you might be asking me about the what is the difference between rhinitis, sinusitis. So okay, when you can have normally this inflammations is caused by infections or allergy. That two most common cause of inflammatory reaction to the nose and paranasal sinuses. Okay, jadi but when the inflammatory reaction caused by infection, normally we prefer the name of sinusitis or rhinosinusitis. But if the inflammatory reaction, just whether in the nose or in the sinus, but caused by allergy, we will use the term rhinitis only, because this term has been used for since long ago. When it is allergy or non-allergy or non-infective, they tend to call it rhinitis. So whether this is allergy or non-allergy rhinitis. But when it comes to infections, they will call it rhinosinusitis. But as you all know, the inflammation can be caused by infection or allergy. Okay, we go into non-infective rhinitis or sinusitis, rhinosinusitis. The big one is allergy, and another one is non-allergy. And I think the allergy one, if you look back at the topics that I've given you last time in year 2, it can be further divided into seasonal and perennial. So in our country, this sort of what we call perennial type of allergy rhinitis is most common. It's not seasonal. Seasonal in the temperate countries, it's 4 seasons. Okay, in non-allergy rhinitis, vasomotor rhinitis, or the other name is intrinsic rhinitis. Okay, so but there are others as well that we will discuss later. So as I said just now, in our country, perennial allergy rhinitis. So the definition of this allergy rhinitis is inflammatory reaction to the mucosal membrane of the nose, IgE mediated. You must mention IgE mediated. So IgE mediated, apa ni? What's called inflammatory reaction, IgE mediated, following exposure to air allergens. Of sneezing, itchiness, nasal itchiness, and rhinorrhea. Okay, so it is mediated by what we call hypersensitivity type 1 hypersensitivity, or anaphylactic type, or immediate type of hypersensitivity. So in this hypersensitivity, you must go back to your what we call immunology class. So you know, that's in this type of this is pathophysiology of hypersensitivity type 1. So the most important, you must know the mast cell here, mast cells that being sensitized. Being sensitized, that means the IgE has attached to it or tagged to the cells. When it tagged, that means it becomes sensitized. Okay, so when there is primary exposure, first exposure, because after this, in this type of allergy, you must have primary exposure and subsequent exposure. So in the introduction, there must be primary exposure. Okay, so yeah, the technical issues, yeah. Okay, we continue. So in this type of allergy, I think okay, I think you must be familiar with this antigen presenting complex, which eat the what we call display an antigen complex on the surface, which is recognized by T cell T cell receptor. Okay, and then okay, sekejap. Okay, the details about this pathophysiology of hypersensitivity type 1, we have to go back to the immunology class, where after the mast cell has been sensitized, and then there's subsequent exposure of aeroallergens, there will be cross-linkage. Then after that, after the cross-linkage, there will be what we call a release of preform mediators. I think preform mediators, I think you all know, which already there, already packed in the cells, already formed in the cells, just waiting for the cross-linkage to happen. When it happened, then when the cross-linkage happen, the cell will degranulate and release preform mediators. In these preform mediators, the most important mediators is histamine, but there are others like heparin, neutrophil, chemotaxis factors, serotonin, and others. Okay. At the same time, if you look here, there is also the beginning of newly synthesized mediators from membrane phospholipid here. Okay, so I think you still remember in this two pathway from the arachidonic acid, there will be two pathways, cyclooxygenase, lipoxygenase. Eventually, this lipoxygenase will produce leukotrienes, whereas the cyclooxygenase will produce prostaglandin. And then, mind you, this cycle or this pathway can be blocked. Like here can be blocked. Cyclooxygenase here can be blocked by NSAIDs and aspirin. And then this leukotriene can be blocked by anti-leukotriene receptor. Okay, so leukotriene is a very powerful bronchospasm. It causes bronchospasm. So that's why anti-leukotrienes, Montelukast, Zafilukast, is commonly used by respiratory physicians like Dr. Hao. But for us in the ENT, we concentrate on antihistamine. We concentrate more of histamine release from the preform mediators. Not much about we do not care much about the leukotrienes. Okay. What else? Okay, preform and newly synthesized mediators. And then you must know in this allergic rhinitis, the triggers for allergens, normally aeroallergens, and the most common is dust, house mite, and the others like animal fur, animal dander, mold, grass, pollen, everything. Actually, this allergic rhinitis, if you know about asthma, it is more or less the same. Because in the asthma also, it is mediated by hypersensitivity type 1. And also there are mediators, and also they share the same triggers, aeroallergens. Okay. And the clinical presentation in allergic rhinitis, they are normally patient symptoms. Main symptom is sneezing. When they got exposed to the aeroallergen, they got sneeze. When you sweep the floor near them, they can easily got sneeze. When they start sneezing, and then itchy nose, and after that they develop very thin clear rhinorrhea. Blocked nose normally later, maybe half an hour later they develop nose block. So because nose block, we call it late phase symptom due to late phase reaction as a result of its mediators from the newly synthesized mediators, not histamine. Histamine normally cause immediate reaction, very fast, sneezing, itchy, and also rhinorrhea. Okay, this kind of disease normally occur in classic history, occur in childhood, more prevalent in childhood. As they grow older, the disease become less and less. And at one time, maybe it will, what we call, like disappear by itself. Okay, so comorbidities in this disease, most of the time, if you ask patient with asthma, most of them will have allergic rhinitis. So in the literature, if you go into the literature, if you sample 100 patients with allergic rhinitis, you will find half of them will have history of asthma. On the other way, if you take 100 of asthmatic patients, you will have 70 to 80% will have concomitant allergic rhinitis. So they sort of comorbidities, they coexist. So allergic rhinitis, normally comorbidities, most common asthma, lagi apa lagi? Skin, eczema, and allergic conjunctivitis. Okay. So when you, from the history, normally when you ask, you must ask about the history of comorbidities, any history of atopy. Okay. And then when you examine the nose, in ENT, we do specific examination for the noses. For this condition, we do anterior rhinoscopy. Okay, we do anterior rhinoscopy with a good headlight, with a nasal speculum. We must look into the nose, but normally what we see inside the nose is edematous mucosal lining with the enlarged boggy inferior turbinates. We can't see much inside because everything got the edema, the mucosal edema, and everything so congested inside. So, but the most important, you must know, the examination is anterior rhinoscopy. There is another examination at the back, examination for the posterior part of the nose. We call it posterior rhinoscopy. That one we use mirror to see with the headlight. Patient open the mouth, then you use like a dental mirror, then you can, with the reflected you can see the reflected image of the posterior part of the nose. Okay, that posterior rhinoscopy. But normally for this condition, it suffices if you do anterior rhinoscopy. Okay, as I said just now, it is normally occur in the young. As they grow older, they become less and less. Eventually, they disappear, and the kind of self-limiting disease. And the diagnosis of this condition is easy. It's a clinical diagnosis. That means you do not need to have sophistication, do not need to have CT scan or do ultrasound or whatever things. It's just clinical, what you call, with a good history and good examination, you must be able to diagnose the disease. So, but there are special investigation that normally we do in the research normally. We do not do this routinely in our clinic because it involves costs like skin prick test. Skin prick test. So this is a special test that where we prick the skin and put the antigen there, and then we wait for 15 minutes. Eventually, we can read the result. It is like Mantoux test, but Mantoux test is intradermal. You go deeper. But in the skin prick test, it is very superficial. Very superficial. You can prick as many as 30 prick in one go, and you can test for 30 allergen at the same time. And you drop one drop of allergens, and then you dab it and wait for 15 minutes, and you see wheal and flare. So you can read further about this, but this is not mandatory for the diagnosis of the allergic rhinitis. And the other thing is radio or RAS test, radio immunoassay test, to detect specific IgE. Okay, in this disease, as I said just now, when you examine, just now examine the nose, but yet if you do general inspection, you can see they have horizontal nasal crease at the nasal bridge. Why? Because they always rub their nose upward. We call it nasal salute, because they want to relieve itchiness, or that they rub the nose upward with the palm, and then they develop horizontal skin crease at the nasal bridge. Okay, yang tu kalau if you see that, you can say that this is typical findings in allergic rhinitis. And the other thing is that they can have allergic shyness. It's like water bag under the eyes. It is like you are deprived of sleep. You don't have enough sleep, so it becomes edematous, bluish in color. We call it allergic shyness. Okay, so in the treatment of this disease, so bulk of the patient that come to our clinic, they have allergic rhinitis when we diagnose. The treatment is same like asthma. If you go back to asthma, how do you treat them? How do you manage them? First and foremost, you give advice. You educate them. And so the first is always avoidance of something avoidable, allergen that can be avoided. Kalau let's say if they have to practice, do not use the thick carpet, the woolly curtain, do not expose to the dusty environments, all that. So avoidance is number one. And then after that comes the medications. So normally, as I said just now, we give antihistamine to combat histamine release. So we give antihistamine. So there are lots of first generation antihistamine like Piriton, like polaramines, but this first generation antihistamine have quite what you call the side effect, can cause drowsiness, sleepiness. So that's why nowadays less people use this first generation antihistamine. So normally we give a second or third generation, like loratadine. There are lots in the market. So, but basically they are antihistamine tablets. They can take one tablet every day. But more important than that, we do give antihistamine, one. Second is intranasal spray, topical intranasal spray. So if you go back to asthma patient, so normally they have inhaler. So that means they use two type of inhaler normally, Ventolin inhaler and steroids. So in the asthmatic, normally they divide into they have two strategies. One is what do we call it? Preventive. Prevent, how to prevent the asthma. One is prevent the asthma. The second thing is second asthma
controller.
Controller. Yeah. One is controller. Then the second is if you got the attack already, you use Ventolin, bronchodilator. So in allergic rhinitis also the same. If you have very bad badly congestion, you can use decongestant agent like Iliadin nasal spray, that decongestant. But normally this decongestant you cannot use long. If you use every day, twice or three times a day, if you use more than 1 week or 2 weeks, you may end up with a condition called rhinitis medicamentosa. When you use for a long period of time, more than required, instead of decongest, the more you use, it becomes more congested. So it is not recommended to use decongestant more than 1 week. Here in Malaysia, sometimes we allow up to 2 weeks, but in US, UK, normally they put it 1 week. So 1 week, you have to stop the congestant if you use twice or thrice a day. Okay, that one very good if you have very badly congested nose. But this decongestant more of symptomatic relief, very fast relief. The more important than that is intranasal steroids, inhaled steroids, like inhaled steroid in asthma controller. They use steroid, inhaled steroid to control the disease, to control you from getting acute attack. So same for us, to control the nose, we use intranasal steroids. There are a lot of intranasal steroids in the market. Of course, the newest one is like Avamys nasal spray or Nasonex nasal spray, which is better compliant to the patient because these newer nasal steroids is odorless and tasteless. When they spray, they don't feel anything, no taste, no smell. and then they have less side effect compared to the earlier generations. So the names like Avamys, Nasonex is common nowadays. We use in the hospital. Okay, for information, Nasonex, so the drugs inside is mometasone, whereas Avamys is fluticasone. All these are steroids. Okay, this is mainstay of treatment. Normally, when the patient regularly use this intranasal spray, they do not need decongestant anymore. They use regularly every day. So, but how long can they use? The patient might ask you, how long can I use this? Because this is steroids. So the answer is that you can use very long time. In fact, in some patients we give they can use every day for 5 years, 6 years without obvious side effect. So because this steroid use only topical or inhaled steroids. As you know, steroid has a lot of side effect. If you give intravenous or if you give oral, you cannot give long. Intravenous, more severe, more shorter you must give because there are side effects. But for the inhale one, you can give very long. So, but normally we strategize the treatment like in asthma, macam we call it step up and step down. Normally, at the beginning, they use regularly every day. So after few months, normally one bottle will last for 1 month. After few months, they can step down. Maybe the symptom become control, okay. They can use every other day. So the technique must be right, it's not easy to show you here, but when you go into clinical later on in the clinic, we can show you how to use the nasal syrup correctly, like inhaler. If you do not use correctly, the effectiveness will be less. So the usage must be correct. So normally we give at the beginning every day, and then they can step down when the symptoms control well. But let's say when they space out every other day, every 2 days, then later jerebu datang and the symptom become worse, they can always use daily dose again. They can step up again until the symptoms well controlled. Okay, then tadi I cakap tadi kita bagi antihistamine, and then now kita bagi intranasal steroids. So macam mana kita nak bagi yang mana? Both or we choose. So normally it depends on the severity. If the disease have a good control with intranasal steroids, normally that one enough. You don't give antihistamine. Dia ambil itu je every day. Okay. In the severe form of allergic rhinitis, sometimes intranasal steroid is not enough. They need to top up with the antihistamine. So they can take antihistamine 1 day, 1 tablet a day, or every other day, depending on their requirement to control the symptoms. But in our clinic, most of the patients, when we start intranasal steroids, is enough for them. So it's sufficient for them. And then for your information, normally intranasal steroid is the main drugs we use for allergic rhinitis. Antihistamine dah jadi nombor 2, only when they require only. But in certain conditions, sometimes patient prefer to use antihistamine. Ada patient yang kata, dia do not like intranasal steroid but like to use antihistamine. Okay, they can use antihistamine, but they have to take daily dose lah. Okay, and can take for long period of time. Okay, what it does just now, like antihistamine, it will suppress histamine release. But steroids basically is anti-inflammatory agent. It suppresses the inflammatory reaction to the nose and to the airway. So when it suppresses the inflammatory reaction, the nose become less congestion, less edema, and then when all this become less, the secretion less, the sneezing less, all the symptom less. Okay, so but by suppress the inflammatory reaction. Okay, so we go back just now. Allergic rhinitis, inflammatory disease of the mucosal membrane. So if you can suppress the inflammation, that's good. Okay, so that's why we give intranasal steroid is a mainstay of treatment. Okay, in rarely in 1 or 2 patients, we give intranasal steroids, we give antihistamine. Sometimes not enough, we give them anti-leukotriene as well, but not many. Maybe in many patients, ada seorang, 1 or 2 that require that. Okay, but in respiratory clinic, they use Montelukast, anti-leukotriene regularly for nearly all patients, because this, as I said just now, this Montelukast, Zafilukast is powerful bronchoconstrictor. Yep. I'm still dekat sini kan? Okay. Yeah. Okay. So, sorry lah, I tak tukar slide. This is triggers, okay. And this is allergic shyness. And this is, you can see allergic shyness here. You can see horizontal nasal crease here. Okay. And the mediators. Okay. So that's treatment. Okay. So in some patients, after many years of treatment, they realize the symptom become less and they take less medicine. Eventually, they do not require medicine because the thing has gone. They say the disease has cured. But actually, as I said just now, this disease has the ability to have a self-limiting. Like asthma, macam asthma kan, sometimes masa kecil-kecil they are quite severe, but as they grow older, eventually at the age of 12 ke 10 ke, they disappear. Mungkin the mother said due to bomoh or what, but actually this disease can be self-limiting. So in the self-limiting ni kita panggil what do you call? The term they use is natural desensitizations. So normally they are naturally desensitized. Okay, so that's why this disease very rarely you found in orang asli, because normally they do not seek treatment. Even though they have symptoms, they just go on with the dust, everything. Eventually they are naturally desensitized. They do not require medications. Okay, so what happens if you do not treat this disease well? It has sequelae lah. So aftermath. If you do not treat this disease, as you know, the nose, at the back of the nose, there is opening for the ears. We call it eustachian tube opening there. So kalau you do not treat well allergic rhinitis, the mucosal edema, all that can cause eustachian tube dysfunction. So bila this happen, the patient can have chronic ear disease. They start with the acute, but eventually, if you do not treat the allergic rhinitis, they become chronic disease. So they can have ear sequelae like acute otitis media, ataupun they can have otitis media with effusions, or they can have chronic otitis media. And then when they have this chronic ear problem, normally they will have hearing problem as well. So that's why in patient with allergic rhinitis, it's better you treat it what we call adequately. If you neglect the patient, they might be having ear sequelae. Okay, what else? I think that's about allergic rhinitis. Maybe you can go back to my handout last time in year 2. I think I have given you as well this one. Okay, the other one is non-allergic rhinitis. The other arm is non-allergic rhinitis. As I said just now, dalam banyak-banyak ni, like atrophic rhinitis, medicamentosa, chemical induced, emotional exercise induced, it do happen, but not that common. Not that common. The one that we see a lot in our clinic, apart of allergic rhinitis, we also see vasomotor rhinitis. So vasomotor rhinitis, also we call it intrinsic rhinitis, which is idiopathic. Yeah? So we do not know the cause why, but it has been postulated that this kind of rhinitis is caused by imbalance of neural activity to the venous or vessel sinusoid in the nose, because in the nose there are lots of blood vessels there, a lot of venous sinusoids, and then it has dual supply from sympathetic and parasympathetic. I think when you learned last time, the vessels only innervated by sympathetic alpha adrenergic or something like that. But there are certain part in the body, it has dual supply. So one of it is nose. So nose has dual supply, parasympathetic and sympathetic. Okay. So because of imbalance, maybe parasympathetic is more predominant. So it will cause non-allergic rhinitis. So the main symptom is not sneezing, not itchiness, but they are more nose block. They come with nose block. And when you examine the nose congested, but not really, not obvious mucosal edema or that, but they complain of nose block, boggy inferior turbinates, all that. Okay. So the other condition is rhinosinusitis. When you say rhinosinusitis, you mean infection. So as I said just now at the beginning, rhinosinusitis, it could be allergy or infection. So tapi bila allergy cause, we do not name it rhinosinusitis. We call it allergic rhinitis because the name has been established long ago, or non-allergic rhinitis. But when it caused by infection, we will call the term rhinosinusitis or sinusitis. So it is an infective cause of rhinosinusitis, and as I said just now, it is divided into acute, chronic, and subacute. But in the what you call in clinic setting here, we just divide into acute and chronic. Yeah? For academic purpose, we divide it into 3, but in real life, in practice, we only divide into 2. So Like less than 1 month, we call it acute. More than 1 month, we lump together as chronic rhinosinusitis. Okay, so but when you answer, if you answer a question like essay or that, when they ask the divisions or how do you classify, you must go like this lah. Chronic rhinosinusitis more than 3 months. Subacute is in between 1 month to 3 months, and less than 1 month is acute rhinosinusitis. And in the chronic rhinosinusitis, there is condition we call it polyps. You can see polyps inside the nose, and there's a other condition in the chronic disease also, but there is no polyp. Okay, in acute rhinosinusitis, you can have acute bacterial rhinosinusitis, which very important here, and also acute rhinosinusitis mostly caused by acute viral rhinosinusitis. Bacteria only small portions, small portion bacteria. But if you got bacteria, it is more severe, and then you must give antibiotic and whatnot. Okay. So classification. Okay, this is a little bit on acute bacterial rhinosinusitis. When you say it is bacteria, or when you say it is viral. So when we look here, the incidence of viral URTI is about 6 episodes per year in young children, whereas in adult very much less. And secondary bacterial infection of viral URTI of the paranasal is estimated is about up to 2% in adult, whereas in children much higher. So prevalence of bacterial infection that cause acute rhinosinusitis is estimated to be 2% only. So you can see, but the viral cause or causes account for 90 to 98%. So you can imagine the bulk of the disease in rhinosinusitis is caused by viral. When you got URTI, I think you all know kan, URTI mostly caused by virus, like rhinovirus, respiratory syncytial virus, banyak lagi. All this kind of virus can cause acute rhinosinusitis. When you have this URTI, you tend to have headache, rasa heavy head with the purulent nasal discharge. So that means you have acute rhinosinusitis at the same time. Okay. But as I said, mostly up to 98% caused by virus, which does not require antibiotics. Only small portion caused by the bacteria. So, but even though it is small, we must be able to differentiate between viral and bacteria, or you must have index of suspicious viral or bacteria, whether this is viral or bacteria. Okay, so macam acute rhinosinusitis caused by viral. So normally viral URTI tend to resolve within 7 to 10 days. Okay, or they have steady improvement by day 10. Okay, and they normally have low-grade fever only. Low-grade fever or no fever, feel feverish, but not really fever. You feel like feverish, but when you take temperature, it is normal. Okay, but in acute bacterial rhinosinusitis, okay, the symptom persists with no improvement for at least 10 days. That means kalau it's prolonged more than 10 days, you must suspect, you you must have suspicious of bacterial infection. Okay, or you have severe high-grade fever with purulent nasal discharge and facial pain. I mean, even though it just started yesterday or yesterday or today, but when it start with high-grade fever, straight away high-grade fever, and purulent nasal discharge and facial pain. So you must suspect straight away bacterial infection. So it's warrant to start with the antibiotics. Okay, or you can have like double sickening. Mula-mula it's like it's like they are okay, but so at the beginning it's steady. It's not that worse. It just steady, but at one time within 10 days it worsened. Within 10 days it's worsened. So suddenly develop high-grade fever, cough, or that. So you must suspect acute bacterial rhinosinusitis. So in this, if you have these criteria of these kind of things, you must be suspicious of bacteria. So why it is important? Because whether you want to start antibiotic or not. So the issue is that of course, you have to have a good judgment, because we do not want everybody to be started with the antibiotic. Sebab kalau you start everybody with the antibiotic, eventually dia akan dapat bacterial resistance. So we do not want that. So that's why it must be some guidelines to guide you to start antibiotics. Okay. So common bacterial pathogens, this virus, I think you know, strep pneumonia, Haemophilus influenza, Moraxella catarrhalis. Okay. Okay, this is terms that we use in rhinosinusitis. Recurrent acute. So recurrent acute, that means when they have acute disease, after that with complete remission, completely cured for at least 10 days interval. And then after that, few weeks later, they develop again acute infection. So if there is more 4 or more episodes in a year, we can categorize it as recurrent acute rhinosinusitis. Okay. Okay, how this thing happen, the pathogenesis of rhinosinusitis. Okay, this you must understand. Okay, so the pathogenesis, so mainly it's a local cause, and it is due to fluid retention in the sinuses. Why the fluid got retention? There is retention because normally it is due to ostial obstruction or opening of the sinus get blocked. At the same time, they also have mucociliary disorders. Okay, so these two ostial obstruction or opening of the sinus get obstructed, blocked, and mucociliary dysfunction or disorder will cause fluid retention in the nose. Okay. When there is fluid retention in the nose, the bacterial will come and cause infection, because this fluid actually is a good food for the bacteria to thrive. So macam you all see in the surgery. In the surgery, biasa when they do surgery in the abdomen, apa kan? Eventually they put drain. So what is the purpose of the drain? To drain out the seroma, or the fluids. If this fluid accumulate there, it's not good, because sooner or later this fluid can get infected and become pus. Okay, same for the patient backbound or coma. So you have to flip the patient left and right regularly, so you don't keep the patient stay supine like that, because eventually they will have fluid retention, and the effect of fluid retention will eventually cause pneumonia infection. So anywhere in the body, when there is fluid retention, the next thing is infection. So do not allow the fluid to get accumulated. So why this ostium, or the opening? You can see here the opening of the medullary sinus here, medullary sinus, and all these sinuses has own opening to the nose, to the nasal cavity. And then, as I said just now, the most common cause of rhinosinusitis is URTI. When you got viral infection, the mucosa inside the nose got inflamed and causing edema, edematous tissue. Eventually, this edema will cause ostium blockage. From the big ostium, it is small or totally blocked. When it blocked, then there will be fluid retention. Why there is fluid retention here? Because inside the sinus, there are cells. There are cells. This lining is living tissue. It's not dead tissue. It's living tissue and lined by cells. And this cell mainly is pseudostratified ciliated columnar, or we call it respiratory type of epithelium. Okay, so interspersed between this cell are goblet cells. These goblet cells will secrete the transudate, or the secretions that will make the sinus moist or damp. These sinuses cannot be dry. Dia macam oral cavity, cannot be dry. If it dry for too long, it will crack, it will cause a lot of problem. So it must be moist, and this moisture is provided by goblet cells. And these fluids secreted by goblet cell eventually will drain through the ostium here, okay, by the mucociliary clearance. If you look here, the ostium is up here, it's not down. So that means kalau down here is easily cleared by gravity, but this one is not, is positioned high up. So to make the secretion move up here, you need active transport, active cilia function. So the cilia must be functioning well. So if the cilia is not functioning well, even though the ostium here is patent, you tend to have fluid accumulation here also. Okay, so you must have good patent ostium as well as good mucociliary function. Okay, jadi if you look back here, there are two main causes of fluid retention. One is ostium become blocked, obstructions, and second is mucociliary dysfunction or disorder, or it could be combined both. So ostial obstruction just now, as I said, mainly due to mucosal swelling, from smoking, URTI, swimming causing URTI. So anything that cause edematous mucosa will cause mucosal swelling, inflammation, and mucosal swelling, and eventually the ostium get blocked. Okay, but there are conditions where the ostium is patent, but mucociliary become disorder in certain disease like primary ciliary dyskinesia. This kind of disease, if you remember in internal medicine, like what disease? Primary ciliary dyskinesia, Catagenous syndrome. In this syndrome, or in the primary ciliary dyskinesia diseases, the patient tend to have recurrent pneumonia. Eventually, they develop bronchiectasis, and then they tend also to develop recurrent acute rhinosinusitis and chronic rhinosinusitis. And also, they tend to have, they also become, apa ni kita panggil ni? Infertility, because the ciliary is not beating well, the egg cannot be positioned well, or the sperm cannot be moved to the intended positions. Okay, so the other things like cystic fibrosis. Cystic fibrosis also cause fluid retention, but it is not due to ciliary weakness or ciliary disorder, but in cystic fibrosis, it is due to thickened secretion, kan? So the secretion becomes thickened. You must read back what is cystic fibrosis and why it becomes thickened. So the secretion becomes thickened and heavy. The cilia cannot have good clearance of the fluids. So it could be mucociliary, like primary ciliary dyskinesia, mainly ciliary disorder. But in cystic fibrosis, it is more muco disorders. Okay. Okay. So as I put here, you can see the pathogenesis, the main pathogenesis. When somebody has URTI, you can see the inflamed mucosa here, edematous, ostium become blocked, and then it will impair ventilation of the sinus or sinuses. So this ostium meant for ventilation, mainly ventilation. Okay. And it disturbs pressure equilibrium. And then eventually it causes acidosis here because CO2 retention. And this acidosis will impact the ciliary function. Okay. Okay. Oh yeah, if you go to Genting, not Mount Everest, if you go to Genting, at certain height you feel like your ear is blocked. Your ear blocked. Kan? So ear tu sama macam ear tu, the ventilation occur through eustachian tube. But it is same as the ostium here for the sinus. So eustachian tube to ventilate the middle ear, but the ostium for the sinus to ventilate the sinuses. Okay, so what happened if you got your URTI, become edematous, ostium becomes small or blocked? The ventilation is not enough. As you all know, normally gas exchange occur readily inside the sinus and outside the sinus. Outside the sinus, that means in the nose and in the atmosphere. Because let's say when the cell lining in the sinus uses a lot of oxygen, it uses a lot of oxygen, guna banyak, and eventually it produce CO2. So CO2 will be high, O2 will be depleted. So dia akan readily through this ostium in the normal circumstances, dia akan the higher pressure oxygen from outside will go in because the oxygen pressure inside the sinus become low. Oxygen has been utilized. CO2 in the sinus, which is high, produced by the cells, will move out into the environment. So it's readily happen. But what happen if this ostium become blocked? The air trapped inside the sinus, the oxygen will be utilized by the cells, and the cell will produce CO2 a lot of CO2. So that become acidosis. And as you know, in the environment, even though the oxygen only 25%, most is nitrogen. So this nitrogen, what will happen to the nitrogen gas? Eventually, it will get absorbed. It will absorb into the mucosa, into the vessels, all that. So not only they become acidosis, but it become negative pressure inside here, inside the sinus. Okay, so when it's negative pressure, it will pull the cell inward, then eventually more and more secretion will be secreted, and then eventually it becomes fluid retention like this. Okay, so when the secretion not change in color, only clear colored secretion, we call it pre-suppuration stage. It means not infected yet. Only the fluid become accumulated there. But when the germs able to creep and goes into the sinus, and then the infection will set in, and the fluid turn yellow. Then when you blow the nose, you can see yellow or greenish secretion coming from your nose. Okay, so most of the time it will resolve. About 90% or more, it will resolve because it start normally, as I said, caused by viral, maybe a small amount of bacteria, but body humoral, what you call immune system will get ready and will combat this infection, all that, and it will resolve. But on this small percentage will go into complication of rhinosinusitis. So that complication you must read. So complication, it can goes to the eye, it can goes to the brain, it can goes to the mana lagi? It can go to the dental. Or it can cause osteitis of the bone here, bony osteitis, ataupun osteomyelitis. But in the nose we call it osteitis. Why it is osteitis? Because when you say osteitis, osteomyelitis, both are inflammatory reaction to the bone lah. But osteomyelitis is bone with the marrow. Normally long bone, you got osteomyelitis. But in the nose, it's not blood producing bone lah. It's just a small bone which has no marrow. So when the thing become inflamed, infection, we call it osteitis. So dia ada bony osteitis, dia akan jadi very hard bone here. Okay, there is special one, the pathogenesis of rhinosinusitis. I said just now mainly due to fluid retention, due to ostium get blocked, or mucociliary disorder. But this is special one, dental cause. Dental cause, on and off you see in the clinic. That means the infection from the dental causing rhinosinusitis, and this is special to the maxillary sinus. As you can see here, the maxillary sinus is, the floor of the maxillary sinus very near to the roots of the teeth here, especially the molar and premolar, very, very near, and some even recently in one patient you can see the root protrude into the maxillary sinus. Okay, so it may happen like that. So as you look at the anatomy of the tooth here, tooth can be divided into two here. One is crown here, which you can see, and then the embedded one into the gums, we call it roots here. Okay, this is root, 2/3 of the tooth. 1/3 only crown that appear that we can see, and this crown area, the outermost layer is enamel, the hardest layer, and then after that, after the second layer is dentin, and the third layer after the dentin is pulp, dental pulp. So dental pulp, basically dental space, which from the crown here goes to the roots here. So in this dental pulp, you can have neurovascular bundle here. So normally what happen if we have small cavities here, gigi belubang, in the enamel, we don't feel anything. So if we wait a bit longer, enamel can get, the full thickness of the enamel has been eroded. So the cavity become deeper, goes to the dentin. So masa dia kena dentin, you still tak sakit lagi. Okay. So nampak, but the cavity become deeper. But when the cavity appear in the dentin, it will move faster because dentin is softer. So when it goes to the dental pulp here, then you start experiencing pain because there is a neural the nerve here. Okay, so that's why if you have small cavity, cepat-cepat to get tampal lah, get it done. So if not, it will progress, and then eventually you will have toothache. Bila you got toothache, normally the cavity is deep enough and goes to the here to the pulp. When it got inflamed here, it start pain, and more severe, not only inflamed, but it cause like abscess. Abscess can go to the apex here, apex of the tooth here. So the apex here, so we call it periapical abscess. So it can burst through the thin plate of floor of the sinus and then appear in the sinus here. So the infection from the roots here can go into the sinus. So if somebody or someone come with the recurrent maxillary rhinosinusitis, you must check the dental status, whether dia ada gigi berlubang ke, ada very bad tooth ke. So normally you will find one or two, or maybe some of the patient has history of tooth extraction, molar tooth, but when they extract, some of the roots stuck there, left behind. Some dentists, sometimes when they extract the tooth, if they do not careful, they left one or two roots there. This root can become infected. We call it tunggul lah. It's a roots. So this is a source of infection to the maxillary sinus. So you have to refer back to dental, let it clear the roots, and okay. If the root is still, if the overall tooth is still okay, you can treat the maxillary sinus easily. You can give antibiotic or you can remove the pus. But if you do not treat the tooth here, it will recur and recur. So when you refer to dental, normally they advise after they x-ray everything, they will do canal treatment, root canal. So those days, if you got infection down to the root, they will simply remove it. Those days, but nowadays they try as they could to preserve the tooth or the teeth. So normally they will advise for root canal. So they will drill and remove the infection of the roots here, put some antiseptic, antibiotic, make it sterile, and then they put kind of cement there, and eventually they repair the crown here by putting the artificial crown. Because for you to approach the roots here, you have to sacrifice the crown. They have to drill out the crown, drill the crown, tinggal remnant saja. They go to the roots here. So when they satisfied with the roots, the roots clear of infection, when it get ready, they put a permanent cement there, and then they have to repair the crown. So you have artificial crown, which costs you few hundreds. Kalau if you extract the things, extract the whole thing, even worse, because bila you extract je, next time you kena buat dental implant. So how much it costs? Here about 3 to 5,000 per tooth. Kalau you buat root canal, it's much what they call less than that. Okay, this is the one that I explained just now, the stages of caries or the caries. This start at the enamel only, and then dentin, and then eventually to the pulp, causing pulpitis, and then eventually cause abscess here. Okay, it's easy. So how do you diagnose rhinosinusitis? So there is few guidelines here. So one is Infectious Disease Society of America here. They use presence of two major or one major and two minor. This is minor symptoms, and this is major symptoms. Purulent nasal discharge, purulent discolor posterior nasal discharge, facial congestion. So if you got two or one here, two here, you can diagnose. Okay, this is used by Infectious Disease Society of America. IPOS, this is European society. They use their criteria for diagnosis of rhinosinusitis. Macam you should have one, either nose block, obstruction, congestion, the same thing, or nasal discharge with or without facial pain or banyak, and then endoscopy, you kena nampak polyp, mucopolonicia, and CT scan. So for you to diagnose, you not only have clinical things, but you must have endoscopy and also CT scan findings. Okay, most of the time in Malaysia here, we use American Academy of Otorhinolaryngology, head and neck surgery. This one is the simplest, easiest. For you to diagnose, the patient must have three cardinal symptoms. Okay, they can have, they will have nose block or nasal congestion with purulent nasal discharge, nose block with purulent nasal discharge, and facial pain or congestion. So this, if they got this cardinal symptom, you can clinically diagnose them. So the others is will help you in make your diagnosis stronger. The headache, halitosis, cough, dental pain, all that. Okay, so for us here in UIA and most of the center in Malaysia, we use this because easier for us. Kalau you guna European, you need to have CT scan, endoscopic signs, a lot of things. Okay, this one, infectious disease, also okay. Some centers use Infectious Disease Society of America here. Also can. Okay, so nasoendoscopic findings, you can see here, I think you must go back to your anatomy, you must study the anatomy. To mind you, ENT is surgical based posting. Dia macam orthopedics, macam apa lagi? Orthopedics, surgery, ENT, neurosurgery, all those surgical based. That means kalau if you in the surgical base, your anatomy must be strong. Kalau you are in the medical base ni macam internal medicine, pediatric, psychiatry. So there are more of pathogenesis here. They're not much into the anatomy. But if you go to orthopedic, they emphasize you on anatomy. Dia akan tanya, this bone is left or right, this bone is up or down, what muscle attached here, this muscle supplied by what. All these things, first and foremost, is anatomy. So same for us, ENT, the emphasis is more on anatomy. You must know your anatomy well. Okay, so in the nose, you must go back to your previous too. You study the anatomy of the nose. So at the lateral wall of the nose, you will find turbinates, inferior turbinates, middle turbinate, superior turbinates. So there is area here, middle turbinates, middle meatus region. So this middle meatus region, for the ENT, we call it osteomeatal complex area. So kalau biasa you learn anatomy, they call it middle meatus. If you go to ENT clinic, they call it osteomeatal complex area. So why it is coined this term? Because over here, it's a complex area, osteomeatal. There's a lot of meatus here, a lot of ostium here at the middle meatus. A lot of ostium here. Opening for the maxillary sinus, frontal sinus, adenoid sinus. Almost all the sinuses open at the middle meatus region, except for certain sinus like posterior adenoid sinus open the superior meatus. Sphenoid sinus open the sphenoid recess. Itu aja. Yang lain-lain open at the middle meatus or osteomeatal complex, OMC, bukan OMG. OMG, oh my god, osteomeatal complex area. So you can see here, this one is the disease. This is left side of the nose. You can see the septum here, middle turbinates here, middle meatus here. You can see very clear. But here you can see the septum here, also left, middle turbinate here, and you can see pus. You can see pus. You cannot see the sinus because sinus at the side more lateral, and there is wall between the nose and sinus. You cannot see the sinus, but you can see the pus coming from the sinus. Okay, like this, you can see polyps near nose, right nose, septum here, middle turbinates, middle meatus. You can see polyps coming from the middle meatus region. Or you can see inferior turbinates here, polyps. You cannot see the middle turbinate because huge polyps here. This is sure kalau you jumpa polyps macam ni, this is a chronic rhinosinusitis because polyp cannot form in short period of time, within few days or few weeks. No, normally when the polyps start to appear, it has been there for months or years already. Okay. So as I said just now, complication you have to read. Sorry, I go back. So the causes, signs, symptoms, examination normally as allergic rhinitis, you have to do anterior rhinoscopy and posterior rhinoscopy. And the findings, as I said, in the rhinosinusitis, you expect to see mucopus inside the nose. Mucopus, you can see inflamed and edematous mucosa, and in chronic disease you see polyps as well. Okay, when you do anterior and posterior rhinoscopy. And then nowadays, this examination has been superseded by the nasoendoscopy. Bila kita buat nasoendoscopy, we can see all the way from the front to the back. So it includes anterior and posterior rhinoscopy. So very easy nowadays. We just slide in the scope, we can see everything. Okay, so we call it nasoendoscopy, nasoendoscopic examination of the nose. Nasoendoscopic examinations. Okay, so the diagnosis actually for us for this rhinosinusitis is again clinical diagnosis. It is not required any CT scan, X-ray or what. This is clinical diagnosis. Okay. So we go back to the slides here. Okay, what to reinforce your diagnosis, you can ask for the X-ray. So normally, if you want to have X-ray, the term we fill in the form, we put that we request para-nasosinus X-ray. So when you put para-nasosinus X-ray, automatically the radiographer will give you 3 views. One is Cutwell view, which is fronto-occipital, which good to see to visualize the frontal and ethmoid sinus here, but not good for the maxillary sinus because you can see the petrous part of the temporal bone overlap here. Okay, yeah. So normally with these views you can see frontal and ethmoid sinus. Okay. Oh, they give you another view, Waters view. Waters view you can see frontal sinus also, but not as good as this one. But you can see maxillary sinus as well. Maxillary sinus. Okay. Or if you work at the emergency later on, somebody come with the facial injury following car accident or motor vehicle accident, this is a good view, Waters view. You can see the fracture outline of the orbit here, outline of the sinus. So you can see a lot of things in the Waters view, or occipitomental view. And the other view is lateral view of X-ray here. So they give a lateral view, you can see sphenic sinus, maxillary sinus. Okay, so the findings could be like this. Kalau you can see here meniscus sign, air fluid level. Okay, ataupun you can see mucosal thickening here. Mucosal thickening mungkin is a chronic disease. The mucosa becomes thickened and eventually it forms polyps. Okay. Okay. That's X-ray. Sometimes kalau macam ni you can see easy lah. But sometimes if the pus full, I mean the maxillary sinus fill completely with the pus or fluid, there is no air fluid level, you can see opacities only. You must compare to the other sinus. Opacities, complete opacities. Okay, this is CT scan, which is we do not order for all patients. We only order the CT scan for those who diagnose rhinosinusitis that will undergo surgery. That's a mandatory. We must do CT scan. Or patient come with rhinosinusitis with the complication, with developed complication, especially orbital complication or intracranial complication. Or they have impending complication. Bila dia datang to the clinic, they have rhinosinusitis and they're a bit delirium, or maybe patients become delirious or become what they call become confused with the time, place, all that. So with the impending intracranial infection or with the swollen eye, we must do CT scan. Okay. But kalau if you do, if the patient requests, can I have a CT scan just to diagnose? No, we don't do. We do not entertain that. They can go to private. Okay, so how do you treat rhinosinusitis? So mainstay in the acute disease, most of the time is medical treatment. We give topical nasal decongestant. Topical nasal decongestant, we try to decongest the nose, open up the blocked ostium. The ostium get blocked just now. So we open up the blocked ostium, let it drain back. And if we suspect caused by the bacteria, we can give antibiotic, which is penicillin based. So normally we give augmentin. So amoxicillin plus clavulanic acid, or sometimes we give Unicin. Okay, sometimes patient allergic to penicillin, we give them erythromycin, or we give cephalosporin. Plus minus metronidazole. Metronidazole is azole group. It is for what do you call, for apa ni kita panggil ni, metronidazole for infection. It's not gram negative, we call it apa ni, anaerobes infection. So normally when the infection complicated by the dental in origin, we give metronidazole. We add metronidazole. Then we give NSAIDs. Just now, as I said, NSAIDs stand for non-steroidal anti-inflammatory disease. So not only for pain, because it blocks the prostaglandin, all that, but also it can reduce the inflammatory reaction. So, but it is not steroid. By definition, steroid is the anti-inflammatory kan, but the new one is non-steroidal anti-inflammatory. So it can reduce or reduces the inflammations. Okay, then some center give intranasal steroids, but here we do not practice giving intranasal steroids. Okay, so normally for the acute, topical decongestant, antibiotics, and we give NSAIDs. For the chronic disease, yes, we give nasal irrigation. We give short term of steroids. So even sometimes we give intranasal steroids in the chronic infection. But in chronic infection, normally they end out with the surgery lah. So surgery in the acute disease, we only do for acute rhinosinusitis with complication, with orbital complication or intracranial. So in the acute rhinosinusitis with complication, we proceed with surgery and antibiotics, medical treatment. But as I said, mostly in acute, if they come with no complication, normally medical treatment is sufficient. Surgery only reserved for chronic disease or disease with polyps. So nowadays, the surgery we do called FESS, FESS, functional endoscopic sinus surgery. So I think that's all. This is a bit on the antibiotic guideline, Malaysia guideline. Maybe I give to you, you can read. And this old technique of surgery last time, it's no more doing, people no more doing this surgery anymore. This old technique. I think that's all for inflammatory disease of the nose and paranasal sinus. Any questions from you all? Anybody?
Doktor, just one question. Nak tanya tentang ubat Avami tu, dia steroid based kan?
Yes.
So let's say that if someone yang ada macam mata berair, lepas tu selalu bersin waktu pagi-pagi, can we just simply prescribe ataupun belikan ubat untuk dia Avami tu and then bagi? Boleh ke macam tu?
Avami, dia not only for the nose, because in the study they show Avami is effective for the nose and for the eye. So it can reduces eye itchiness as well, eye irritation. So bila reduce, there will be less itchiness, eye, less teary eyes, all that. Good.
Nak stop bila ya, doktor?
Oh, you can use long until you have the symptom control. If you use every day, you require 1 year. Okay, 1 year, you can every day use 1 year. Because some patients, when they stop, they cannot stop. When they stop, they will have symptoms. They can continue using every day. But as I said, most of the time, after you use a few weeks, maybe 1 month or 2 months, you already feel the difference. You feel a lot better. You can step down the dose.
Okay, and then I've read in the dekat artikel macam dia punya precaution dia cakap akan ada epistaxis. Is it
epistaxis? Oh, yes. Epistaxis tu kalau once in a while we encounter lah. So normally one is that epistaxis due to incorrect use of the nasal spray. They sprayed it towards the septum. We do not advise towards the septum. That's why the correct technique must be emphasized. And then the steroids also is known to cause thinning of the skin or mucosa. Maybe some patients, they react more than the other patients. So that's why it become, or the vessel is more superficial. So that's why it can cause bleeding. But normally in our clinic, not that many lah. Maybe once in a while we see.
Okay, thank you, doctor.
Okay. So may I know who everybody present or how many not present? So because somebody need to take attendance and give, I have to give evidence to the kuliah, those presents. How you do that?
Prof, we're going to provide a Google form later on.
Okay.
You're taking the attendance by that.
It's okay because I need to do that. If there is no question, we can stop.
Okay.
Or anything? A certain thing like complication of the rhinosinusitis, you can read read out by yourself.
Doctor.
And okay, anything? Hello? Okay, carry on. Mana? Somebody called me just now.
In a layman term, doctor.
Is on and off your voice. I think maybe you want to ask in the layman's term of rhinosinusitis or resdung. So in our, because in this part of the world, in this region, Kelantan, Terengganu, Pahang ni, this thing, when you say, some come with complaint of sinus. Some say, oh doctor, I've got sinus, straight away. So bila kita tanya, what do you mean by sinus? I've got this. Okay. The other things, ada kata, saya ada resdung. Saya ada resdung. So ada resdung, bila kita tanya, oh they give this. Ada even yang kita they say they got resdung. When we ask what the symptom is, nothing, is no nasal symptom at all. Tapi because of jerawat, anak saya ada jerawat ni, so dia ada resdung kuat. Because of pimple, only because of pimple. So that's not right. Okay, so normally, most of the time when they say resdung, they have nasal symptoms. And most of the time when it comes, the bulk of the patient mainly they have allergic rhinitis. So when we explain to the patient in layman's term, we say the resdung is divided into two, infective and non-infective. So non-infective too, more of allergy. So, and it appears in the clinic, most of them are allergy or non-allergic rhinitis when they come, because they come with the sneezing, running nose, occur in the morning, have background history of asthma, atopy, all that. So yes, you can say they are resdung, but this is not kind of infective type of resdung. This is allergic type of resdung, which is not dangerous, but it's troubling. Yeah? They cannot concentrating in the class. The boys or the girls cannot concentrating in the class because they have to take care of their nose. So they have to use the medicine every day. But the other, if they come with a pure rhinosinusitis, the infective type, that's the one that I explained just now. They come with a persistent nose block, one side with the facial pain, discomfort, purulent nasal discharge, all that. Okay.
Okay, understood, doctor. Thank you.
Okay. I guess no more questions. So before you come for the face-to-face, make sure you read up about the anatomy. Not only for the ENT, you must read up anatomy of the nose and paranasal sinus. You do the revision, very fast revision, and then anatomy of the ear, anatomy of the throat, of the pharynx and larynx. So I think that's the important things when you enter the surgical base. Okay, I think that's all. Ada apa-apa? Kalau tak ada apa-apa, I nak stop ni. Okay ke tak okay?
Okay,
Okay. Thank you very much for hearing. Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.